Good evening. Welcome to another episode of The Breakdown. Oh, disclaimer. Oh, disclaimer. I'm just going to start right up with there before I introduce our guest because we're talking healthcare tonight, and it's not great. So, to be very, very clear, anything that I say tonight is speaking only for myself and in no way represents any organizations that I am affiliated with or employed by. So let's just be very, very, very clear about that. Because boy, it's gonna get a little tense tonight. I think very excited to welcome back to the program. And we set this date up for a while. It's gonna be my first question. Very excited to welcome back to the program ER physician Dr. Paul Parks. Dr. Parks, thank you so much time for sitting down tonight.
Yeah, Nate, thanks for having me. I've been on here previously when I had some official roles, so it's nice to come back now and can kind of speak a little bit just from my own perspective.
Well, this is the thing. You're all out of all of the the official rules. Could you just talk about that for a quick sec, just so that we have it on the record?
Yeah, well, so a couple things. I mean, I'll re-stress everything I'm saying right now is my own personal opinion, but backed by 25 years of working in Alberta, having just come off spending 3 years on the executive of the AMA as the president-elect president, and then past president representing the entire profession across the province. And then, of course, I've spent for the last 20 years, being a president of the section of Merge. I'm back with the section of Merge as well. Just met with my colleagues on the weekend about just before the weekend again to see my Merge physician colleagues see what the state of things are outside of where I'm working currently, because I'm still working on the front lines too. And then just finished my role as past president. So I'm no longer officially like an official representative of the AMA. And so just stressing again that I have a lot of experience and knowledge and I'm on the front lines and I've connected with my colleagues from many specialties and across the province. But everything I say today is from my own representing my own perspective and concerns around how chaotic and bad our healthcare system is right now in the state of things.
Perfect. I'm glad we both have those disclaimers out of the way. Um, uh, so to start with, speaking only for yourself, what are you here? Like you just got back from a bunch of meetings with a bunch of other physicians. How are things?
Yeah, bad is not even that, that doesn't cut it. It's pure chaos. To me, I've used that word a lot and people are like, it does is it a hyperbole? Am I, exaggerating here? No, like talking to my colleagues across the province and trying to provide frontline care and trying to do our jobs in the healthcare system, whether it's in the emerge departments or my EMS colleagues out in the communities trying to pick up sick patients and bring them in, or my colleagues, like physician colleagues in the hospitals, surgery, cancer care specialists all across the province. It's never been this chaotic and this difficult to navigate, and it's never been this overcrowded. Access blocks never been this bad, where the volumes and the complexity and how overcrowded our system is, just as a baseline, and then adding with the government's refocusing and a lot of the things they've done over the last couple of years, it's never been this chaotic, and we're really worried going into the fall. That we know fall and winter we always have predictable surges in volumes. Always, you can look over the last 25 years we've been tracking it. We know our volumes go up. People get sicker for lots of reasons, and we're going into a really in a really bad state right now to go into the fall, and so it's just pure chaos. People are very concerned, very demoralized, and really worried for the patients of Alberta. And so it's something that's why I want to kind of talk about this and talk about the big broad picture and some of the pieces that everybody should be aware of.
Well, let's start. I mean, we have a bunch of topics that I want to work through here, but let's start with the one that's perhaps closest to your current portfolio. Um, how are things in the emergency rooms or the emergency departments? Because one of the things that I think that we've seen a lot of commentary around is the reality that many emergency departments are finding themselves grossly overwhelmed, and they're finding themselves grossly overwhelmed in part because of the lack of primary family doctors. What are your thoughts on that? Is there validity to that? Are the ERs seeing more things that should be seen in family doctor settings, or I mean, obviously everything's not fine in the emergency rooms based on your answer just there.
No, it was so that's a is we got to be really careful because the emergency rooms are really, really bad, and the access block and what's going on in the emergency departments are really bad. And we can talk. Let's talk in a bit about what some of those big pieces are and what's causing the trouble around that and why Albertans should care about it. But one thing we should be very clear. And I spent the last 3 years saying we need to bolster primary care. We need to make sure family medicine specialists are supported so they can take care of Albertans, and every Albertan can have access to primary care and a family medicine specialist. That's a separate issue that we got to work on, because what that is for is making sure Albertans stay healthy, don't get sick in the first place, making sure that when they do come into emerge, for example, and we can take care of their issues, they have a place to go back to. Same as surgery, if they have surgery, post-operative surgery care, same as if they have cancer care, having someone to quarterback their care throughout their life. That's a critical issue. We still have tons of work to do on that. The government, finally moving on the funding model that we co-created and moved was a good thing. Um, but I got to tell you right up front, there's a bit of a myth out there thinking that it's the simple, easy walk-in things that are going to the emerge and overcrowding our emerge departments. And if we could just divert them back to family docs or to walk-ins or to urgent care, that we'd have no overcrowding or trouble in our emergency departments. In fact, sadly, when we get really overcrowded, it's the walking wounded or the easier cases that are the only ones we can see. Because what happens is our merge departments are so overcrowded, and when I say overcrowded, I want to say, like, if you take let me just pick like the university hospital emerge department that has 60 care spaces in their emerge department. Well, sometimes they'll have 70, 80, 90, 100 patients out in the waiting room waiting to go in. But in the emerge department, there are sometimes 55, 60 admitted patients that need to be up on the floors. 60 out of 60, like every one of their stretchers is admitted with someone with a stroke, or someone that needs surgery, or someone that's had a horrible heart attack and needs to go to specialized care. And there's no care space to care for anybody. And the ambulances keep coming. And the reason that I paint that picture is it's when it's that gridlocked and that blocked up and that bad in our emergency departments, it's the sick patients we can't see. It's the sick patients that need to be admitted to hospital that we can't get to the right place. And it's the new sick patients, really sick patients, that patient that comes in with a bad heart, chest pain, and we see big, elevation on their ECG and know it's a heart attack. We can't get them into a space to care for them. And we're seeing that day in and day out in our emerge departments. And I just use the U of A as an example. All of our major emergency departments are faced with that challenge. So I want to say, getting Albertans access to family medicine and primary care is a critical issue. But this idea of diverting them or easy patients overwhelming our emerge department, and if we just diverted them to walk-ins and to other places, everything be fixed, is a total myth, absolute myth.
Okay. So I guess if and I want to be clear, I wasn't trying to suggest that it's
Mhm.
the fact that people have no other choice. Some people have no other choice but to use emergency rooms as substitutes for unavailable primary care. That's not the. I wasn't trying to make the argument that's the panacea for everything. Uh,
Right.
but one of the reason why I asked the question is I'm pretty sure I saw a post from you a little while ago where you were talking about the fact that you're seeing more and more later stage illnesses presenting for the first time in the emergency room.
Oh, absolutely. So again, that's so a bit. So you know what? So that you're bang on. Why we will need for primary care, and absolutely why it's the foundation, is we don't want people to get so sick to that they get to the point of being critically ill and needing emergency care and hospitalization. So an example that you're bang on is cancer care. So we are seeing, like, very advanced cancers regularly in the emergency departments, and it's very sad. It's very difficult. It's very demoralizing for the team and the patients because it's a very crowded, busy environment that is not. We don't know them. We don't have a relationship with them. This can't be private. There's no real dignity in these emergency departments as hard as we try to provide it because these conversations could happen in a hallway, because they're not in a care stretcher. But so yes, we are seeing very delayed and very sick patients because they didn't have primary care. And why is that? Because the proper screening wasn't done and the proper types of preventative kind of steps that would catch things earlier. All those pieces, absolutely why we need primary care, robust primary care. But once those patients do come into our emergency department, some of them are so sick they need to be admitted into hospital, and there is no room and there's no space, and we can't get them in there. But in addition, some of them really need very fast and quick diagnostic imaging, so CT scans, MRIs. Some of them need really quick referrals to the cancer specialist, whether it's the medicine cancer specialist or the radiation cancer specialist. And sadly in Alberta, like I could see someone that might need that referral. Like I see them in emerge with a very advanced case, and it could be 14 weeks, 16 weeks before they see a specialist to start their care for their very advanced cancer. So it's very complex, Nate, and you're bang on that it's all interwoven, and we have to kind of address multiple pieces of it because they're all connected. But right now in our acute care system in the hospitals, it is volumes and complexity of how sick patients are, and just the fact that there is no capacity in the system, and workforce challenges that we're really struggling with in Alberta.
What would you say are the biggest factors contributing to the capacity issues? I mean, I know that the premier likes to point to the one case of that one person who was in hospital for I think it was like 700,000 days or something. I'm I'm being grossly hyperbolic there for the record.
Yes, yeah.
Why don't we have the capacity? And then my follow-up to that is going to be, what do we need to do to address that capacity?
And that's something we've known for, sadly, for 25 years. I've been advocating on this issue, and so have some of my colleagues and experts. And so this is, to be really clear too, and I should have said this at the get-go, anytime you kind of criticize the healthcare system, it seems very partisan. It seems like, I'm just, you're just hammering on the one government, or you think it's ideologic and it's just because they're right wing or left wing, whoever's in. There's only one government taking care of it. But to be fair to this government, they've inherited a mess in terms of a long term of some things not working, like not having done, hospital capacity. We haven't had a hospital in the Edmonton zone, for example, for a long, long time. And then, of course, they make choices like deferring and not building a hospital. The current government not building a hospital in our Edmonton zone, which doesn't help us at all. But things like long-term care capacity and continuing care capacity, it's such an interwoven system that really our biggest problem by like obvious glaring anybody that looks at it is the patients that their care has been taken care of, and their acute care and whatever need it might be. You could picture, someone's your grandmother who's 9 years old and has a pneumonia and comes in a hospital for a while, and we get them better, but they're not well enough that they ever can go back home independent. And they need to go to somewhere, whether it is supports in the community or a facility. Those resources simply do not exist. And so that patient then is taken care of in the hospital, but they become what we call an alternative level of care patient and an ALC patient. And they get stuck and stranded in the hospital system for days, weeks, and sometimes years. And that's because we don't have the adequate capacity in the long-term care system or continuing care system to get them out. And just to give you some numbers, like it used to be, even probably 2017, 2018, it would startle us if our ALC numbers, our alternative level of care numbers in the province got above 400 or 500, and we'd be like, oh, this is getting problematic. Sometimes it'd spike a bit more, but as a baseline, if it stayed like that, it'd be disastrous and we'd have to do a lot of things. And now, today, currently right now, I haven't seen the last numbers in the last couple of days, but we're talking almost 1,800 alternative level of care patients are in our hospital system in the province right now. Almost, if you take it rough numbers, if you take out, maternity beds and certain things, psychiatric beds, and maybe we have about 6,000 total health like hospital beds in the entire province. Almost one third of them are patients stranded who can't get out into the community. Think how many hospitals that is in numbers that would be freed up if we could address that problem, and if we could kind of move on that problem. And exactly what you said, which is really, startling, is that number just keeps going up. In the last 2 years, it's skyrocketed. I sat next to the premier about a year and a half ago where she quoted numbers and said it's our biggest thing. We have to do a priority to fix this and get moving on ALC and try to figure out getting those patients in the right place. And sadly, they've really focused on really, really complex patients that have been in the hospital for years that have really high needs and really special needs. And the premier herself has admitted that in 2 years, her SWAT team and her team, using all of her efforts, has placed seven of those really high needs, long stay patients. And meanwhile, the numbers just keep going up from like 1,600 to 1,700 to 1,800 ALCs, and our whole system is just totally paralyzed. And what that means, everything I just said sounds so complex, but what that means is that when you break your leg and smash it up really bad because you're out biking or whatever, and you need a surgery, and you come into the emerge department, and you're going to be sitting in all, maybe you come in with the ambulance, maybe the ambulance isn't available to see you and pick you up off the street where you broke your ankle. And that's red alerts, which we can talk about. But then you come to the emerge, and you might spend 12, 14 hours in a hallway with on a stretcher before you can see me. And then you might spend 3, 4 days in the emerge department, admitted, waiting for your surgery because there's no beds up in the hospital because of those stranded patients that are ALC patients, because there's no capacity in the hospital. So that's a long answer to just tell you it's so complex and interwoven, but we have solutions and we've been trying to provide them, but this government is just not interacting and working with us.
I mean, as I was listening to you there, it strikes me that, you know, I think you said seven have been placed, which is a small number. Um, there's got to be some like lower hanging fruit in that uh patient group. There's got to like, I mean, getting seven really complicated ones off is great, but if you could have maybe gotten like 200 of the less complicated ones, that would be to me more of a win. Is there a reason why they like help me understand that?
Yeah, well, I mean, and it's a little more complex than that, in that they've obviously placed some of the easier patients as well. But one of the things that happens is, as an example, these seven that I give you as an example, these are patients, very like extremely complex patients that need very special care to get out. So, but there's lots of those. There's hundreds, a couple hundred of those, and in a couple of years we maybe they'll break down the ALC patients around really high needs, complex versus less versus even less. And so they are placing some of the other ones, but what's happening now is making up numbers as they place 700 of the lower ones and spend tons and tons of energy to try to place those seven really complex ones. 800 new patients come in and become ALC. So the number's growing faster. And so, but why now, might you say, why is the number growing faster than what we can deal with? Well, there's a couple pieces. One is we have way higher population. They're way more complex and living longer. But in addition, we can predict for that. There's smart mathematicians, there's smart people out there that can know what capacity we should have, but we have not been building the capacity in the community. And then the government came and did refocusing and siloed everything. So everything I just told you about trying to come into the emergency department with your broken leg or your heart attack or your stroke and how it affects the whole system's connected. Well, the answer to fix that is now in assisted living Alberta, and it's with Minister Nixon. And Minister Nixon's aware of this, and their team is trying to work on it, but they don't have any accountability for it. Their budget's not affected by the fact that there's 1,780 ALC patients in the hospital. They don't have any connection with me or my colleagues in the emerge department, who are struggling and having red alerts and overcapacity and all of these things we're trying to do to just do our job on a day in day out. They're fully disconnected, and there's no operational control between the acute care Alberta, the hospitals, and the assisted living Alberta, zero integration, zero operational control. There's nobody working trying to connect those two ministers and trying to solve this problem. And that's times that by four, Nate. That's our system now. It's totally siloed, totally broken down with no integration and no operational control.
Yeah, you kind of stole my pivot from me there.
Okay, well, we could talk more about it.
I
So
was,
that's
well, that's one of the things is that in the former healthcare system, which I believe was one of the fifth best in the world, as much as people don't like to acknowledge that reality, um, in the former healthcare system, that patient that you just described that maybe has the pneumonia, is she's traveling through the emergency doors, maybe through the ambulance stuff, which is now also a separate department, in through the emergency doors, which is now acute care Alberta, in through the hospital, which I think is still acute care Alberta, but it seems to be open to some interpretation. And then if she has to access additional pathways, that's an entirely different organization for all intents and purposes. And in the former system, before it was disintegrated, and that's literally the word that I've been using for a while now, in the former system, you could have somebody go, I'm Tammy's case manager, or I'm the person who's gonna look at Tammy's case, and they could be working for Alberta Health Services, and they'd be able to track her all the way through all of the different things, and they'd be able to say, "Hey, we're failing this person. We need to do better." And all of the levels of or levers of power were in effect in the same organization. I'm not in any way suggesting that AHS was a flawless organization, because I'm not crazy. But at least it was in the same house. Now it's not even in the same house, it's in different cities. What are your thoughts on refocusing is such a nice word. Like, what was out of focus, I guess, would be the question that we required refocusing. I don't know. I'm gonna go with disintegration. What are your impressions, your thoughts on the disintegration of healthcare in Alberta?
Yeah, so I'll say a couple things. I'll preface by saying, was AHS perfect? No, I mean, I've worked in 25, well, no, I've worked in Alberta 25 years. AHS came around 2007, but were there lots of things that could have been fixed and repaired and or made better? No question. So to just stall all the haters out there that just think I love AHS and wanted it to forever be the exact same. No, but on the flip side, was there really objective? Like worldwide, looking at different healthcare systems, objectively saying how we're doing in integration, how are we doing in terms of our administrative level of how many bureaucrats do we have per people working, all these things where we had really good objective measures on that, a lot of that stuff. Was there anybody, this isn't just my opinion. So when I go across the province now and try to talk to anybody on the front lines, anybody that's like healthcare experts, people that have been working, is there anyone that said, blow this thing up, disintegrate it, cut it into a whole bunch of disconnected pieces? No, like nobody. In fact, where this came from is still a mystery. Was it done on the back of a bar napkin and then given to consultants and said, make this work? I don't know. I would love for the premier to tell us who came up with this and what experts said this would be a good idea. But then what I do know is that then they handed it over to the system to consultants. And the consultant firms that are not experts in this and are not delivering the care were just given orders to try to say, hey, you know what, try to make this work. And for the last 2 years, they've been trying to push a square peg into round holes when everybody in every front has been saying that, this is not working, right? So I got to say personally, for me, I was there day one in it was like end of October, early November 2023. As the president of the AMA, I was one of the first they showed this to, and I said, do you want my real opinion of what will be the weak link of this, what will be difficult? And ministers were there, the ADMs, like everybody, and they said, yeah. And I said, well, we can see there's no operational control and no integration. We can see how they're not going to connect. We have to have this. Like, if you don't have this, the system's doomed. they created a working table to say, hey, let's try to get some input in there. But unfortunately, that working table was literally just bureaucrats coming to tell the physician experts. So I pointed, it wasn't just me, it was, experts in psychiatry, experts in family medicine, experts in hospital-based medicine, and experts in the continuing care. And say every time they'd be going, listen, we need this, or we have to have some operational control. And the bureaucrats have as much as said, listen, we do not have marching orders or any direction to have operational control or integration. Our orders were to blow up and destroy AHS. And that is what we have done. And now we were told to try to make this system work, and that's what we're trying to do. And now, fast forward 2 years later, and we really truly are in a state where not only is it so disintegrated, but now they've created a state, Nate, where Albertans have to understand this. They've created an environment where it's actually going to be competitive against each other, and it's going to be in the best interest of these organizations to downplay and blame each other. And to say it's not my problem, it's a them problem, because what's been happening, they've been firing every administrator you can think of who's tried to give truth and try to speak to these people and say this system isn't working, or this needs to be done, or maybe have you thought about this. I'll give a really concrete example that I'm sure you understand and live and people understand. They've broken EMS off now and put it in its own little area as its own little org. And then there's hospitals, whether it's Covenant Health or AHS, they're their own entities now that are just going to run hospitals. And then there's this big acute care agency around it. Well, now as we go into red alerts, meaning there's no ambulance anywhere in the area, and you call all of Edmonton zone. There's not a single ambulance ready to go for the next person that has a heart attack, a car accident, life-threatening, not breathing. There is no ambulance. Those red alerts are happening regularly across this province, and I want to talk about that more. But we have more red alerts, and then we have EMS offload issues, meaning they have to come to a really overcrowded emergency department that has no space. But their job is to take that patient, bring it to us, and as best and quickly as they can, expertly give it to us, and then get back out to do the new stuff. We need to create protocols because we're so overloaded and overcrowded to try to help that work. Well, so red alerts and offload, EMS offload as an example, we're now in an environment where the EMS leaders are going to fight with the specific hospital leaders to try to duke it out as to what can be done, and it's going to be in at the it's going to be to the benefit of the EMS leaders to say it's the emerge department's fault and it's the hospital's fault and vice versa. And there's nobody coordinating this gong show. There's nobody above saying, hey, listen, let's look out for the patients. Let's try to do this in an organized manner. And you know what? People will say this is an exaggeration, but I think the premier has alluded to this, if not said it, but you could envision really quickly that let's just pick a hospital in Edmonton. Let's pick Stony Plain, that they decide to, basically in some contractual way give to some company, call it Google, let Google run it, like whoever. We're gonna have a Covenant House, we're gonna have AHS, and we're gonna have Google run in our hospitals in Edmonton. And then we're gonna have EMS, its own entity, and they're gonna try to, how do you deal with it? What if Google, or what if entity X, I don't want to get myself in trouble, but what if entity X says our hospital's not taking ambulances? We're closed. We don't take ambulances because we're making our own local leadership and we're doing our own thing because the premier wants us to do our own thing. You can picture how chaotic that is. That's what we're living every day, man. Like every single day. We just haven't sold off any of our hospitals to these third party entities, but I think that's something the premier has said she wants to do.
Yeah, she has. I mean, and to go to your question of whose idea this was, Daniel Smith has uh, credited the source of this idea to herself.
But then we would have the Alberta Health Quality Council do us an auditor function and tell us whether or not Alberta Health Services should continue running the Lougheed Hospital or the Rocky View Hospital or South Campus or any of the 100 hospitals that they currently run in majority in the province. And if they can't meet the terms that we want them to, we can do an RFP. And then the Alberta Health Insurance can give a different contract to a different group of doctors and a different group of patients and a different entity to run all of our hospitals.
On multiple occasions. And so that's another, I one of the challenges that I think exists is you have people who don't have that internal operational knowledge of what are all of the pieces to this puzzle, and how do we make sure that the things that need to happen, and they go, ah, I watched House once. Here's what I do. And I think we're at the point now, regrettably, where even if you wanted to make the argument that AHS as an organization was like an injured patient. Maybe AHS got into a car accident and it's got like a concussion and a broken hand and a broken leg. The solution to treating that patient appears to be draw and quarter it. That'll
Yeah,
work.
and that is what they did, to be honest. And I gotta say, your analogy around, so if the premier has admitted she came up with this plan, so this is what's happened since then. And I don't want to necessarily get myself in trouble with consultants either, but the consultant firms have they are making unbelievable amounts of money to be consulting the government, where they get told by the premier and or the premier's people, here's our plan, tell us how to make this work. And then they get paid a lot of money, even if the facts and or everybody they come talk to, like myself or other leaders in AMA or other leaders in AHS or Covenant Health or anywhere, say, that's not really going to work, this isn't going to work, this is trouble. They don't listen to that piece, because that would be biting the hand that feeds them, to go back to the government and tell them that this plan won't work, we should think of other things. They just continuously are trying to put square pegs in round holes and ignoring the experts. And I want to say, I said this out there somewhere, but if anybody has some time, like, somebody should FOIP how much money this government has spent in the last 2 years in consulting. And the problem there is on the books. I don't think you might find, like, I've heard numbers of like $1 million a day, Nate, like over 300 million, $350 million in consulting fees, those kind of things, but they get spread around. They might be in contingency funds. They're not in operational funds for healthcare, for example, but the money still be spent. It's tax dollars money. And, like, again, I can't get those numbers, so I can't tell you what it is, but nobody's blinked when I've heard numbers like $1 million a day to go to consultants in some way to try to make these systems and these problems, try to fix them, right? I mean, they're doing it with the laboratories, they're doing it with everything. It's these, they come up with an idea and then they go ask the consultants make this idea work, but they've totally cut out the experts or the people that are running right, like on the front lines, that might have a clue what's going on.
Well, going back to that drawn and quartered analogy with the consultants piece, what you're describing sounds to me like maybe Daniel Smith said, "Oh, that AHS patient that's been in the car accident, we're going to treat it by drawing and quartering it." And the consultants, rather than going, "That's a terrible idea, we shouldn't do that," are instead going, "Okay, but first we're going to need to figure out what's going to work best. Should we use a spoon? Should we use a butter knife? And what brand? What is the best brand of butter knife for drawing and quartering? We really need to make sure we explore all of our options." And at a time where the healthcare system is in collapse, that is perhaps, and I'm just speculating here, I'm not a consultant, is not the best use of taxpayer dollars unless you're a consultant.
Well, and then the big part is, what's the outcome? Look, like now, that's what, regardless of how we got here now, we are in a scenario where it is just objectively, there is nobody out there that will deny that we are in a situation where we have the most alternative level of care patients we've ever had. We have the most EIP, so emerge inpatient patients we've ever had at the end of the summer. We've used So a lot of things, like, for example, over the last year or two, we created surge capacity, and we had some surge beds in hallways and in areas in different hospitals. They've become permanent. Like, we've surged to the point of where the surge is part of our functioning, where sometimes our hospitals are 110%, like 110% capacity. It's only designed for 1,000 patients, and it has 1,100 every single day. We got no surge left. And we're going in. So we're in a scenario and then the big piece of your analogy too of the drawn and quarter is, it's actually, there's a bit of a more of analogy too of, in addition, it's the hydras, the mythological hydra. You cut off one head and two comes. That is what's been happening now. Right now, we have in healthcare, we went from one minister to four ministers, four CEOs now, from one and two CEOs maybe to four CEOs, and then administrative branches beyond that. This government was like very vocal about saying there was too many administrators in AHS was one of the reasons they had to draw and quarter it. And now we have objectively more than four times the bureaucracy and the administration and the administrative cost. But even if, that didn't make you really angry about taxpayers' money going into all of this extra redundant administration and bureaucracy, in addition, it's the Hydra analogy: chop a head off and two more come. And there's like 10 heads out there that nobody has a clue who you'd go to try to fix some of these solutions, because all of the pieces of the healthcare overlap, like we've been discussing. And so do I go, when the emerge department is desperately overcrowded, do I call up Minister Nixon and say, hey, can you help me? Or do I call up Minister Jones? Or are they talking? Or is there anybody that's even coordinating this? And the answer is no. Like, it's not. It's not working. And it's not working for Albertans. And that's what I want to focus it back, is the outcomes because of this broken system are patients are dying of cancer that could have got treated. Patients are dying of surgical illnesses that could have got treated, or they're having very bad outcomes. Patients are having, heart attacks and strokes and bad things in our waiting room. Patients are suffering. Albertans are suffering, and we should be able to do way better. And the outcome of all this abstract hydra drawn in quarter refocusing is that patients are hurting, and our system's not working for them.
I want to talk a little bit about the staffing piece, if we can, because one of the things I took a look today, and for the record, today is we're recording this on the 28th um, of September. Um, just to be clear, I took a look, and one of my sort of favorite unhealthy fixations has been to take a look at the surgical center that exists in Edmonton that has now been closed in varying degrees for a year and a half. This is a surgical center that was custom built to do orthopedic surgeries, and it hasn't been operating at capacity. And the reason that we see for that is staffing. There are staffing shortages everywhere. And I want to get your thoughts on the staffing piece, but the reason why I want to ask about it is because we also saw a news story come out this week where Airdrie Region Care is getting like $6.2 million in that number might not be exact, but a lot of money, buckets of money. In renovations, it's going to add roughly 40% extra treatment space, and there's no commensurate increase for staff. So in effect, what they've done is said, hey, you know how you're really busy at work already? What if we made you 40% more busy and didn't do anything for you? Um, Talk about that.
Yeah, I mean, yeah, it's a bit mind blowing a little bit when you think that we had such a big healthcare system. And right now, I'll just be blunt and say it: there is nobody doing workforce planning in this province in a coordinated, system-wide fashion. There'll be lots of people saying, "Hey, we're trying to look at how, this little piece here, or that little piece here, or this little piece in our own little area," but nobody is doing it in a concerted fashion in any way. And so exactly what you're highlighting is like the government just looking to try to think about, what is our current state of what's our need for physicians and for nursing and for allied healthcare workers, for EMS, for paramedics, you name it all. I mean, and the amount of, what is our current state? What's it look like with our sick leave, which is off the charts in terms of sick leave and absenteeism, and what our everyday work is looking like because of the stress and the burnout and the moral fatigue. What does it look like right now in our province? What would be our future state that we need optimally? And then how would we try to do this in a coordinated fashion? Well, everything I just said about the Hydra, think about the Hydra, and you cut off the AHS head, and now there's a bunch of them. Well, they're all now not only not thinking about this in a coordinated way, they're actually starting to fight with each other about workforce. Because if you were to think of, let's take, mental health, and let's take, counselors or mental health nurses, or you can picture right away, any Albertan can know that they could work in the acute care hospitals, or they could work out in the community in Recovery Alberta, or they could work in both. And we need lots of them, and we don't have enough of them. But who's trying to coordinate that? Just that little small piece. Is it Recovery Alberta? Is it the ACA and the acute care organization? Are they starting to compete against each other now to hire the same workforce? Yes. Like, they are actually going to be, and there's going to be, not only are we looking at this in the environment of a shortage of healthcare workers through the whole nation. So all of Canada is struggling with this. So we're competing with other provinces for all of these allied healthcare workers and physicians. But now we're setting up an environment where within our own system, we're competing with ourselves for the same workforce in our own system. And it's just pure chaos. And so everything you were just saying, and now if you want to think about that, look at that analogy. Let's just look at simplify the acute care world now. So we have Covenant Health, who's going to be trying to hire people for all of their hospitals. There's going to be AHS who runs their hospitals. And then there's going to be these chartered surgical facilities that are going to try to run their facilities. And then there's going to be urgent care centers that are going to be run by other people that are going to try to staff their centers. And nobody's coordinating it, despite the fact that we know they draw from the exact same workforce. So the hospitals right now, every day, anesthesia as an example, our anesthesiologists, we don't have enough of them. So more and more of them are moving out into the community, into the CSFs, meaning that we don't have enough anesthetists to work in our hospitals for the life and limb threading things on an everyday basis. And people will say, Paul, you're exaggerating. Let me give you an example. In Calgary, we regularly have diversion for our surgical patients, meaning if you pick on any given day, there's not enough staff in our big hospitals to do cases like appendicitis, gallbladder disease, but tears or holes in your bowel. You could go to the foothills as an example, and they might be on diversion that you have appendicitis. You show up at Foothills, one of my colleagues sees you, says, "Oh yeah, you're pretty sick. You need surgery." We have to call an ambulance off the street to take you to say Peter Lougheed or Rocky, because that's the only place that has a team to do that surgery. That's a regular occurrence in Alberta because nobody is thinking and coordinating our workforce strategy for anesthetists, as an example. Let me give you a merge. I'm very concerned. I live this every day and I'm in there. We don't have enough emerge physicians and emerge nurses in all of our big emerge departments as it is right now. But for some reason, the government comes out and announces they're going to do 7 more urgent care centers, in addition to what they're already building in Airdrie, as an example, but not having thought in one, you're not having asked anybody that works in emerge or is an emerge expert that's in the zones or in the new corridors saying, would that be a good idea? Would it be a good idea to have one in Medicine Hat? Would we be able to even staff it compared to what we're staffing in our emerge department, let alone forgetting to ask us that we actually have an area in our emerge department that we could turn into a walk-in if we had staff and have it separate but connected. But nobody's asking those questions. So again, these things are so complex and interwoven and interconnected, but nobody is doing this in a coordinated fashion, and it's only going to get worse and worse and worse. To the point where the premier said she wants local hospitals to do all these local decisions. You can just picture how in a zone like Calgary or Edmonton, the hospitals are going to be starting to fight with each other to try to get staff. That's what we're leading to. It's so reductive and it's so chaotic and disintegrated.
Well, and that's the other piece. I mean, like one of the things that I find fascinating about the the strategy here, and I mean, Danielle Smith was very, very clear a few years ago that her vision included if we're not getting the results from a healthcare hospital, like a hospital or a healthcare department that we want to get, then we can always bring in a private organization. Like, I love how you pivoted from Google to Elon Musk, by the way.
Some of
Uh,
these big guys that they promise to fix the world, but they won't necessarily, right?
You give money to Alberta Health Insurance. It's a separate entity. It's a government entity, so it's publicly administered. They are forbidden from running any programs or any hospitals themselves. Alberta Health Services becomes the contractor. Sure, we can grandfather in their contracts for now, but then we would have the Alberta Health Quality Council do us an auditor function and tell us whether or not Alberta Health Services should continue running the Lougheed Hospital or the Rocky View Hospital or South Campus or any of the 100 hospitals that they currently run in majority in the province. And if they can't meet the terms that we want them to, we can do an RFP. And then the Alberta Health Insurance can give a different contract to a different group of doctors and a different group of patients and a different entity to run all of our hospitals.
But if you have a private company, and this is something that the chartered surgical facilities, which I think are not good. my personal opinion. I think that they are a drain on the healthcare system. I think that the evidence shows that the results can be questionable, as a term I think is called washouts. Um, so, do with that what you will. But a chartered surgical facility or private hospital, privately run hospital, could conceivably, as the same way you were talking about, they can say, oh, we're not taking ambulance patients tonight. It- they could also set different wages, and we do see different pay things happening for different areas. I know that even in the paramedic realm, there are folks that can go do private paramedicine at private events, kinds of thing, and you get paid more. Um, and so to introduce that, like Daniel Smith likes to talk about, competition will be the greatest thing. Well, yes and no. I mean, I think we've seen in the American healthcare system that competition works really, really well if you can pay for it. But if you are somebody who does not have extensive means, it can be catastrophic. Um, and that to me, like when I think about like what it means to be Canadian, there's maple syrup, there's hockey, there's the RCMP, but I think that a big part of it is also we have free healthcare. Anybody can go to a hospital and everybody gets treated the same. And it is not your status that determines your priority. It's the severity of your condition. And to think that we could be moving in any way away from that is, I mean, great, I guess, if you've got bags of money, but if you don't, less great.
Yeah, well, definitely. If you don't, you're gonna die. I mean, we know that, right? Like, so hey, that's not exaggeration. That's a given. So, I mean, let me say, there's a bunch in there. Like, I'm agnostic around the CSFs as an example of, is it possible that private delivered in a private facility with public pay, just so it's very clear that people understand that it's, there's still the same pot paying, is it possible that that could maybe work in certain scenarios and in certain ways, if there's appropriate guardrails and if it's done in a connected fashion, again, like everything we're talking about, making sure the workforce makes sense, making sure that it's not, as an example right now in Alberta, we are, as the more and more that the government pushes it towards chartered surgical facilities that can only do the easier cases. This is not my opinion. They can only do CTAC with ones and twos. Sorry, the operational ASA. But the point being is they can only do the easier cases in this facility, and kind of by definition, if they're very complex and need longer care or very hard, they can't be done there. But if they push a model where only those cases can be done in the sickest and the people who have life-threatening illnesses can't get their care, then obviously that's not working. That is not what Albertans and Canadians would think is a working system. But we're faced with that right now with the examples like the anesthesia example I give you, and the team to take care of post-operative care in Calgary. Like most Albertans and people in Calgary don't know that if you go to the Rocky View on one day or the foothills on one day, you might have to be transferred to another hospital for straightforward surgical kind of cases. So right now, the way that the government is pushing these different types of models with no connectivity, no guardrails, and no coordinated planning is disastrous for us, and it's really causing trouble. But then in the second piece, which you highlighted, is what gets left out of the discussion right now, as long as it's still paid out of the public pot, which is what's happening in Alberta mostly, is that why would you add a profit motive and a profit factor to any of the care done in Alberta if you're going to be the same payer? Because now, would it ever make sense to say, listen, we're going to do a knee surgery in the hospital, but we could do the same knee surgery in a chartered facility and pay 20 or 30% more, or if that was the setup that goes from the same pot. It doesn't make any sense, and people would understand that too. And so that's something where, if we're going to have a model where there's some private delivered public paid care and done in a hospital, we need transparency. People need to know, what's it costing in these facilities, how's it working, is it more efficient, is it not? And I'll tell you right now, in Alberta, we're broiled in a scandal because as people were starting to ask those questions and raise those concerns, they got fired. And I don't want to go into the corrupt care scandal. Let's talk just about the healthcare right now. But I want to say that, people, lots of people have been raising those concerns, around workforce coordination, true costs. And everybody and anybody that does there seemed to be a pattern of they get fired right now and or punished for trying to do it. The list of really, there's such a crazy long list of amazing healthcare leaders, that like award-winning national and international healthcare leaders that have been fired in this province, that it's amazing. We're in an environment now, Nate, where no one wants to even come in and fill these positions right now because of the environment we live in Alberta, with that punitive kind of nature, and no one can speak truth to power. So that's another huge quagmire that we're facing. That's a long answer to say we're in trouble. Like the actual outcomes for patients are getting worse demonstrably, and so we have to correct course.
Yeah, with the profit piece, I mean, eh, I can imagine a situation where once you introduce profit as a motive and people want to get the biggest piece of the pie that they possibly can, I can imagine situations where people may make ethically questionable decisions that might not technically be illegal, that lead to all sorts of very bad things. I don't know if anything like that has happened.
Well, you know what? Let me get out of dangerous territory and maybe give a really obvious concrete that Alberta's already lived through. So our labs, Dynalife, and so our lab. Let me sum that up in a little bit. I'm still waiting with bated breath for the Auditor General to come out and show, to give an eye picture to what that happened. I wouldn't even surprise me if the Albertans and our taxpayers spend hundreds of millions to billions of dollars lost in that fiasco. I don't know the number. I'm waiting to see. But what happened, just to summarize, is if you add the profit margin of 5 to 7% to lab, which is such a critical functional piece of our entire healthcare system. If almost anybody, you're going to need some type of laboratory work. Well, once you start adding the profit margin in there, and Dynalife had to do this, and they were upfront, they were going to do a profit margin. Then the first things in the decisions they do, even if it's not, you're not judging them as being evil or anything, like let's take all that out and say, well, what they do is they look at the things that cost a lot of money and aren't done a lot, and they say we don't want to do that anymore. And because there's not a good profit margin in it, but neglecting the fact that we still need those things to be done in the healthcare system. And so, as an example, I raised concerns a number of years ago in the Dynalife. It was very expensive for Dynalife to do same day ECGs. So if you have chest pain and your family doc wants to get an ECG, Dynalife was seeing that they have to have someone there to do it that same day and someone to read it, and it cost more money than if it was done and had to be, read in 3 days or not urgent. And so they started to phase it out and say, listen, we're not going to do that. And I raised concerns as an emerge chief in my emerge department of medicine, that saying, like, what has happened in our system? Patients are being sent from their family doctor into the emerge departments just to get a ECG. So they'd have to wait hours just to get an ECG that used to be able to be done in our outpatient labs. And when we started looking at it, it was because it cost them money and it wasn't a good profit margin in it. And so it was something. And this is just one example. There was lots of pieces in the Dynalife privatized healthcare lab piece that complicated it, where we couldn't get the critical pieces of our lab services that we really needed, that throughout the whole healthcare system, not just emerge. My example is just one little piece that everybody knows. They went, used to be able to go to the labs and get it in a half hour, and all of a sudden, people were getting quite cranky having to wait 6 or 7 hours in the lab. All those kind of examples. We did this in Alberta. The government had to, this government, who are conservative and ideologically think that private delivery is better, had to reverse on the lab. They had to do a full about face and spend hundreds of millions of dollars to buy that contract out. And whatever the number ends up being, it will be, it should be unsettling to Albertans how much money we wasted on that kind of already wasted on that kind of model in Alberta and in healthcare.
Well, I mean, I'm glad you brought up the labs piece because my understanding is that APL or Alberta Precision Labs has not yet been placed into one of the silos of healthcare. And there's currently an evaluation of sorts being done by, you guessed it, a consultancy firm to determine what the future of APL could look like. And it's not outside of the realm of possibility, given Daniel Smith's stated values for how healthcare should be delivered, that maybe we try again. Maybe we get a different company to try to run it privately again. I've certainly here at the show, we've been getting no shortage of messages from people who are very, very concerned about that. Um, and I think that that's like, to be clear, for a long list of reasons. I'm not suggesting that a private company pursuing a profit margin is evil. I make no moral judgments about those sorts of things, but a publicly run healthcare system that has no profit margin doesn't have to worry about a profit margin. And the fiduciary duty of any private company is to make money. That's why they're private companies. And so that's fine. But when it becomes, the question that I think needs to be asked, that I think needs to be fairly and honestly presented to Albertans is, do you want the primary concern in your healthcare system to always be the best possible outcomes for patients? Or do you want it to be, we're going to make money and we'll also try to do the best possible outcomes thing too when we can?
We'll
Because
take what we can get. Yeah. Yeah. Well, and you know what? Like, to be fair, like, so, because there will be some hate thrown at me and us on this idea. Like, I am again agnostic as to who delivers the publicly funded care. I'm not agnostic about public versus private pay. There's huge issues, and we can talk about that. But who delivers the private, the publicly funded care? If it's in a facility privately done, or if a for-profit shows that they can do it in a way that delivers the outcomes that we desire and shows that they can do it, then okay, let's do it. But that's what's broken in Alberta, is there is no transparency and no accountability as to how our money is being spent. So when these things happen, there's no way for us to look at it and say, and for the government to be held accountable to say, this is how our taxpayers' money is being spent. Here are the outcomes. Here's the proof of how much we spent on it. And look, this model that we decided to embark upon, whether it is a private lab, whether it is some private surgical facilities, whether it's something else they dream up that they think is a good model, there needs to be accountability and transparency saying this works for patients. And so what I'll take it back to now is, right now, why I'm chatting with you and why I'm super concerned. And I just came away from talking to hundreds of physicians, like thousands really across the province, that are very concerned about the state of our healthcare system, is that it's currently broken. The outcomes aren't delivering what we would desire from our money, and fairly, we spend a lot of money on our healthcare system. And so I do believe Albertans deserve accountability from our government of, and transparency of, like, how are we spending the money and what are the outcomes and is it working?
to me, it's just like, all due respect to the agnosticism. To me, if the primary motive was we need to get the best number of outcomes for the largest number of people, and somebody raises their hand and says, "Hey, I've got an idea for how we could run a clinic that only does simple orthopedic surgeries," I don't know. Yeah, I feel like that's a disservice to represent any orthopedic surgery in that way. But the less complex ones, I'll say, probably, and not get quite as much hate mail. Um, here's my proposal for how we could run this clinic. Then to me, there are all sorts of ways to incentivize that internally without saying yes, and now go do it privately. Like, if somebody says, "Hey, I've got a great idea for how we can do this thing. We're going to save money. We're going to ease up the healthcare system. It's going to be fantastic." Then my first words, if I was the president of healthcare, would be, "Excellent, do it, and if it works, we'll buy you a boat." Like,
No,
it's simple.
and I get what you're saying, and you know what, to be, but I have my own personal opinions of some of this because I see what the outcomes are on the front lines of where it's not working and how they end up in the public system. So without guardrails and without making sure certain things are done correctly, it's not working. But there may be an argument, as an example, that some of my colleagues would bring, some physician colleagues would bring forward, saying, you may be able to drive some efficiencies with a small profit margin and things like this. Like, so you can kind of debate and kind of finesse some of those pieces. But what's missing again, and I will say it, is if it's not done in a coordinated, transparent, accountable manner right now in Alberta, what it means, like, let me give concrete examples. If we're talking about, doing these CSFs and not having enough anesthetists, is now, so if you don't look at the big picture, and the premier keeps coming out and just quoting small pieces of the numbers of what the cost is of the CSF, for example, nobody's tracking the fact that, for example, like, this is definitively 3, 4, 5 years ago, if you had your gallbladder, so your gallbladder, you have stones and it gets infected, and you need it to come out because the stones are blocked and you need it to come out. You would get admitted, and usually that would be done within E24, meaning you'd have it out within 24 hours, and you'd be admitted in a hospital, get some antibiotics. Some people could get really sick. Some people can die from that. So we, but on average, we get it done in about 24 hours. Now in Alberta right now today, people can wait in hospital for 4, 5, 6 days to get their gallbladder taken care of and taking it out surgically. Or I gave you the example of, if you broke your ankle and in 3 places and needed it fixed, you used to get that done. We have data, we can see it. You used to get it done in 12 to 24 hours. Now there are people that are waiting in hospital for 6, 7 days. Worst example, broken hips. Someone falls and breaks their hip. Used to be done within, in the average, about 24 to 36 hours. Now there are people waiting in hospital for 7, 8, 9 days. I know of cases where people have tried to sign out AMA from the hospital, leave against medical advice with a broken hip, to try to go to another hospital because they've waited 7 days to get their hip done. So now why I want to bring this all back is that who's tracking how much that costs the system? So those extra length of stay in the hospital, of all of those patients, if you add them up, there's hundreds of those kind of surgical patients, and they're spending days and days longer in a very expensive system. So that's one cost. So who's tracking that? Nobody. Second is, who's tracking the fact that some of those sick surgeries that are new ones coming in can't get patients, I should say patients that have surgical conditions that need to get fixed, need to come in. Who's tracking the outcomes and the waits and the delays they're having because there's no beds, because instead of someone being done their broken hip being fixed in a day, it's taking 7 or 8 days. And then factoring in all of those costs and the frustrations and the difficulties to work in that environment because it's so overcrowded, versus maybe what's happening it's a cost of surgery in the community facilities. And then add who's paying attention to the workforce, that as this gets worse and worse and worse, those anesthetists and the nurses and the surgeons are like, well, this is not working over here. It's kind of broken and it's getting worse. So I'm going to go over and work in the CSFs, and do the easier cases, and I'm going to do what I was trained to do, and it makes the hospital system worse. So there's these so many costs when you look at the system in little fragmented, siloed, disintegrated pieces, and you don't look at the big piece. And that's happening every day. I'm not making those examples up. That is what's happening in Alberta, and nobody's talking about. Just if we were to look at surgical cases, I'm not even talking about patients that have cancers in their bowels that need to have surgery, and the delays, and the outcomes that happen. There's so many examples I could go on about, Nate, but no one's looking at those real costs and the cost to the patients.
Well, one of the other things, I got 3 other topics that I want to hit you with before I let you
Okay.
get to dinner. Um, One of the other things that I've been struck by is Danielle Smith has said that what she wants hospitals to be is the places that you go in, whatever, you get hit by a bus. You go in, you get patched back together, and then off you pop. And that's what she wants hospitals to be.
We know we're heading in the right direction. We have to get our hospitals focused on hospital care. They shouldn't be focused on mental health and addiction or homelessness or people who should be in assisted living or long-term care. And that's how we're separating the system, is that we want Alberta Health Services to be laser focused on delivering efficient, effective emergency care and efficient, effective surgeries. And they can't do that until we start creating other authorities to take all of those other things off their plate. That work is just beginning, and we'll begin to see more progress in the next year. So AHS should not be doing Indigenous health. That's a department issue. They should not be doing public health. That's a department issue. They should not be doing mental health and addiction. That's Dan's job. They should not be doing seniors care. That's the job of Jason Nixon. They shouldn't be doing homelessness. That is the job of Jason Nixon. So we're pulling these things back to the appropriate authority to make our hospitals hospitals again.
one of the patient subsets that I find myself deeply concerned about is the the mental health stuffs, because there are a lot of people for whom accessing the mental health system um, comes through an emergency department. And some of these people will, they're having a crisis. It will be a short-lived crisis. And sure, hopefully with the appropriate supports and treatments, they'll be able to go out and go about their day. Some people that's not the case for. And with a disintegrated system, I find myself deeply concerned because, one of the things that I've heard from multiple places is right now we're not doing a great job of addressing the mental health stuffs for people whose only pathway to access those things is through an emergency department because they've hit that level of crisis. And I want to be very, very clear. There's all sorts of mental health resources that are out there and available, and they work for some people. But when somebody is having a severe crisis and they think that there are spiders under their skin saying, "Ah, you should call 811," is not going to get them to the help that they need. Um, what are your thoughts on, like, A, first of all, am I wrong? Are we doing okay with the mental health stuffs? Or and B, how much worse is it going to get?
Uh, so, should preface I should preface one thing I have to say. I hate being in this position where it's all doom and gloom. I hate being the voice and advocate out here that's trying to alert Albertans and say, hey, we should pay attention. Things are bad. Because I will say, when you get into our system and in pieces and get access into areas, we do phenomenal. We have world-class healthcare. No question in my mind. And it's amazing what we can do when you get into the system and get into the right places and it's working for you, and the teams and everybody in healthcare are working like really hard. Like they're really overworked, like every front from EMS to all the way out to long-term care, every front, everyone's their volumes are really high, the complexity's more, and they're understaffed by a lot. And that's just the regular. So they're doing yeoman's work and they're working really hard and trying really hard. So it's but it's the getting access and it's getting the right into the right care and getting the right pieces. And sadly, I just got to tell you, like our mental health care is broken. Like, and this isn't my own opinion. Like this, I just literally on Friday and Saturday, we're talking at length with some of my psychiatry colleagues from across the province that are the leaders and experts in psychiatry in Alberta, and the moral distress from them around how broken our system is for patients is. It was really disheartening because there's no question. There's a couple pieces. One is having broken up these silos and having everything over in Recovery Alberta and having a focus on recovery when we know there's a lot of mental health that we can stabilize and mitigate and help, but they're never going to recover from it as in be cured. And they can live very, very high quality of life. Like people can function, but again, and there are some that can't. Live high functioning, but still need lots of supports. And the point being, though, is that this focus on recovery and having it out in the community and totally siloed and separated from our acute care world is not working. And even the words in inhumane treatment came up a bunch from my colleagues in the sense of like it's not atypical that we see now in our emerge departments. Like it does break my heart. Like I hate talking about this, but there's patients that will come in with, as you said, they may have schizophrenia and they have very disordered thoughts and are mentally ill, but they could spend 5 6 days locked up in an emerge, like our emerge mental health rooms that's like a padded room with no light, nobody to interact with. Like days is the norm to be locked in there in a loud emergency department with the lights never go out and it's just always chaos in the emerge. Like that's almost the norm now in a lot of our emerge departments. And then there's patients that can end up going up into the hospitals and like when I say, years, I'm not exaggerating. They can be locked in hospital for years. And there is something to be said about, bringing in long-term care as a ALA is another part where we no question have to build some facilities that would what we would be, we need to kind of call them long-term mental health facilities. So as long-term care mental health facilities that we know there's a percentage of patients that will always need some wraparound services and supports, and those don't exist. So regularly now talking to my colleagues, You'll see someone come in for months and be admitted and get stabilized just a little bit, that they get discharged to nothing, no home, no supports. And then in a couple days, the police are bringing them back to emerge, and we're seeing them, and it's this game of catch and release or catch and admit, and it's a vicious cycle, and it's heartbreaking. It's very, very disconnected and broken what's happening with our mental health services and our system right now. And I'll just say there are lots of good people with really good solutions. Everybody always criticizes that it sounds like, healthcare workers and physicians are just bitching and moaning and just complaining about problems. It's like, no, we have a lot of people providing really good ideas, but government doesn't appear to be listening. And then I'll just add them breaking up the system and having a different minister in Recovery Alberta and having, it all kind of totally disintegrated has made it infinitely worse and way worse. And then again, like, it is very, the numbers, like, that is one thing. If you wanted to say what should we start with right now, we should have transparency. We should be right now reporting how many psychiatric patients are held for days and days in our emergency departments across the province, just straight up numbers, so people could see how bad it is.
Yeah. And I want to reframe something you said there, if you don't mind. You can correct me if I get it wrong. You hear the people say that healthcare workers are just bitching, um, and you know, it, I think that most healthcare workers, whether we're talking about nurses or RTs or paramedics or physicians, I think the reason why they say, well, we've got a problem here is because there is an inherent belief that we could be doing so much better than we are. And there is that desire to make sure that people are getting the best possible care that they possibly can. And so it's not that healthcare workers are disgruntled or angry or whatever. It's the knowledge that we can do better and we should be doing better. And if nobody says anything, then we won't, because it will just become the frog will boil, and that'll that'll be that. Um, and I think
Well, can I add to that? Because you're bang on. Like, the moral distress is real, and it is, the part that's boiling over. Like, that boiling frog analogy has come up so much lately that, like, we're really worried that the frog's almost dead, right? Like, that it's so hot and the water is so bad and we are losing people, because we are losing good, paramedics that have worked for 20 years that are burning out and can't do it anymore because. And why is this? Or nurses or physicians even? Why? Because they can see day in and day out the people in trouble that they know they could help if they had the resources, or they knew they used to be able to do better. We used to be able to get them in timely, or red alerts. I don't know if we're going to talk about red alerts, if this is a segue into there, but it's a good example of the paramedics and my merge colleagues seeing, what is a red alert, so everybody knows it's for EMS, that it's literally for an area that would be covered by X number of ambulances and paramedics and crews, EMS crews, that there is no available rig or crew to be able to respond to that next emergency. And that next emergency could be, somebody that's pulseless and dying and needs to be seen in seconds to minutes. It could be major traumas. It could be like we had a case where, a dog mauling, and because there were delays to get there, like, think about the moral injury for a crew that can't respond to a geriatric person that's been mauled by dogs, that if they'd gotten there, 15, 20 minutes early, they could have saved their lives, and they could have done their job. Like, they could have done what they trained for, what they're skilled and what they're excellent to do. And those red alerts are growing and growing, and like, and to the point where, and then add ED closures. Like, I really want to, I want to highlight, like, the lack of transparency around emerge closures in our province now. And we're not talking little tiny little towns that, those are closing too, and that is the problem. But we're talking like centers like Hinton and Edson and bigger. These are stroke centers and facilities where if you have a stroke, you get sent to, and they have CT, and bigger departments like that are closing. There's threats like Brooks might be, suffering and about to close soon, having intermittent closures. Like, these are big emergency departments that serve a big area. And then I'll give you an example. It's not irregular now that and we'll tie it together, is that it's not just a one-off now. For example, that Edson and Hinton are both closed, and so then you have from Jasper all the way basically to the city of hit Stony Plain, that there's an area of 400 square meters or bigger, 400 square kilometers, that are, I mean, sorry, that there's no hospital, no emerge department. And then add on top of it, because any patients that are sicker in that area that ambulance crews respond to, they have to drive hours to the nearest emerge department to take them there. So then there's no crews in those areas. So there's no ambulances and there's no emerge departments in big, huge swaths of Alberta, and nobody's talking about it. And then we see cases, like I know of examples of a 40-odd-year-old male that has a crushing chest pain and collapses, and there's no crew to respond for over an hour, and then they go to the hospital. I won't name them, but they go to a hospital and it's closed, and the crew didn't know it was closed, and then they got to go to the next one. And this is someone that's got, we call it ROSC, in return of circulation, and it's very complicated, and they're dealing with trying to keep them alive, and you're talking hours to transport these people, and then add on top of it that government solution has been to try to add, and it is a band-aid and it works in some areas, but adding virtual emerge departments, where we know a virtual emerge department can have some benefit, but can only take care of what we call CTAS 3, 4, and 5. So patients that are not the critically ill or really sick, and we know they can't even deal with those, and they won't deal with them. But because they have a virtual doctor covering, they don't tell anybody that the emerge department's closed, or don't flag it as closed. But in reality, if you can't take care of the CTAS ones and CTAS 2 patients in an area, you're functionally closed for those kind of patients. And so it just cycles into this day in and day out. These communities, these physicians, these nurses, and these paramedics, as examples in this example, are struggling day in and day out, and seeing 40-year-olds die because they could have saved them, for example, if the system worked the way they saw it working even months ago. And it's sad, and it's very hard, and we need to get those stories, and we have to have that advocacy out, because no one's aware it's happening quite regularly.
Yeah, it's wild to me. I'll speak from my personal experience. Again, reiterating, I'm speaking only for myself and no organizations that ran. Um, I remember when I started in my career as a paramedic, um, and if the city of Calgary had a red alert, that was a holy shit moment. Everybody dropped what they're doing because this was this represented a catastrophic failure and weakness of the system, and we had to bust our asses to make sure that whatever we were doing, we finished it right now, because we had to make sure that there was that coverage in place. And I haven't seen in myself or in any of my coworkers, quite frankly, that same sense of urgency. Like now, oh, it's a red alert. It must be a day that ends in Y. It's not. It doesn't have that same sense of urgency, because you simply can't, as a healthcare worker, you simply can't sustain that level of we got to go 24/7. It will burn you out. And so I think that, but the other thing that I wanted to highlight with the emergency department closure, because I don't know about you. In my experience, healthcare workers all have that like one type of patient, or one, for me, it's like one type of call where I'm like, oh, hell no. I don't want anything to do with this. I don't know what yours is. I'd love to. Um, but for me, it's labor and delivery. I loathe labor and delivery calls, because in my sandbox, there's only two reasons why I ever encounter a labor and delivery call. Either things have not gone according to plan, which is bad, or there is no plan, which is bad. So there's not really like, oh, let's go and deliver a baby today. Like I can think of several physicians that I have as acquaintances, and that's what they do, and they love it because they get to plan their day around that. It's not that pathway in emergency land. And I please correct me if I'm wrong, but I saw that Medicine Hat had no obstetrical surgeons available a little while ago. And this is not like Killam or another small town. This is a major metropolitan center that does not have anybody who is skilled. And I want to be clear. Yes, I understand that there were general surgeons that were available. That's cool and full props to them. But I would like the specialists, please, who are very good at doing this thing because I've seen where those calls can go. Um, can you talk a little bit about the obstetrics side? Because as much as ED closures in the province are bad, what I'm seeing happen to women's access to reproductive health care, and particularly like the birthing part, which is, again, I hate it so much, um, seems to be really horrifying.
Yeah, well, this is not a setup because we didn't pre-talk about it, but there's
No.
no question in that that's mine too. Because in Emerge, when I see delivery, it's not a happy, uncomplicated delivery either. And I mean, I've always worked in a facility that has labor and delivery that has the specialists. So if they end up in front of me, it's bad, and it's definitely not what I want to ever do. And always it's like, oh, let's get the specialist that's upstairs down here now while I temporize as much as I can too. And that leads into why they are specialists. So I'll say like, yes. So last weekend, Medicine Hat Regional Hospital. So Medicine Hat's, you might say it's only got 65,000 people-ish, 70, whatever, that ballpark, not so big, whatever. They didn't have any obstetrical specialists. Well, no, it's got an area. It's the regional referral for a massive area, like from basically the border and Oyen all the way, past Brooks and a huge area of patients that are sent and referred. So there's deliveries done in other spots, but if there's anything complicated, anything that is even, is a sniff of worrisome, it gets done in the hat and will be referred to the hat for that patient population. And it's just it's unheard of to not have an obstetrical coverage in those places. So could we temporize with do we have physicians? Like, I want to be very clear, do we have very skilled family physicians that can deliver babies? Yes. Do we have surgeons, general surgeons that could come in a pinch and probably do a reasonable job in a really difficult area to do a C-section? Yes, but those are like, that's why we have specialists. Like, and I want to really reiterate, like, when whatever the numbers are, is call it 95% of the time the pregnancies go fairly well and things are good and groovy and dandy. When it's that 5% time that things go bad, you're talking like minutes to seconds for the mom's life and the baby's life. Like, this is not, and this is what they're really good at. When that happens, you don't have time to put them in an ambulance and ship them to Calgary. You don't have time to do those kind of things. And then sadly, uh, you know, this isn't just the hat. Having the hat in a regional center, have not have it, is not only like unheard of, but it didn't even really get, announced. Like, it wouldn't have, the government, I don't even know, like, outside of an internal memo that got leaked, but like to the my physician group and to people in our hospital to say, hey, be aware of this. I have no idea if they even notified patients. Like, I don't know if that was something that the government and or Alberta Health or anybody or Acute Care Alberta made aware, and notified people of that's a real risk, right? And then it's happening more and more in other communities, and then you're having more and more where Albertans have to deliver, like, drive hours to go to the nearest delivery place. Like, Albertans deserve to have basic levels of care that we know. You can't have state-of-the-art top trauma centers in every center in all of Alberta. We get it. But you can have regional centers, and you can have a baseline level of services and care that we know, and that's now at risk in even regional centers. And like I said, I want to go back to, like, it does blow my mind to think that a city as big as Calgary, has to divert patients from a big hospital to another hospital because they can't have the surgical teams. Like, we're seeing this in so many fronts right now, and it's a really troublesome scenario right now that it's just growing and growing to the point of where it's this, almost normalization of deviance, where everybody is like, oh, that's just Alberta, healthcare now. And then there's a knee-jerk reaction of trying to, blame the healthcare workers at the facility. It's their fault that they just don't want to work hard enough for this or that. And that's crazy. It's nonsense. The reason we didn't have this coverage, they tried to get locum coverage. They tried everything they possibly could to get the coverage, but our workforce is that pinched and that difficult in Alberta that they couldn't. So it's just something that we have to have some transparency and accountability around how our system's functioning. And now transparency is zero. In fact, if anything, these orgs are going to try to hide this data now. It's in ACA's best advantage. The CEO of Acute Care Alberta doesn't want people to know this is happening regularly, because if it gets worse, that person will get fired. Mental health. The CEO of Recovery Alberta doesn't want people to know that hundreds of mental health patients are spending days in locked rooms in emerge departments, because the pattern from the government has not been to try to, create a coordinated response and fix it. It's been fire that person. And that's the environment we're living in these days.
The obstetrical piece is just like I wish that people understood that most of the time with minimal intervention, I'll say, babies are delivered with no problems whatsoever. But when it's bad, it's so bad. And it's really hard to. The only way that I've been able to articulate it to people is if you take a look at the peripartum mortality rate in the turn of the 20th century, so the early 1900s, it was 50%. Uh,
Yep.
and for those who don't speak medical words, that means that 50% of the time that a woman delivered a baby, either the baby or the mom died. 50%. That's bonkers. And that's nature. And so like to not have the appropriate resources in place for one of the most appropriate and one of the most predictable emergencies is I just can't even. Yeah.
No, I'll add my physician group, so myself and all of my colleagues, we see and do a lot of really intense stuff in our merge, and we're merge experts, and all of us to a T. We're like, this is not normal. Like we do not want to be having to try to intervene on a really complicated, difficult delivery without obstetrician backup, because that is the standard of care, and that's what Albertans deserve. And that's what our system could and used to be able to deliver.
Yeah. Two more topics real quick.
Okay.
Uh, COVID. You talked about we have our respiratory virus season. There's certainly some bugs floating around. God knows I got hit with one about a week and a half ago that just wrecked me. Um, Getting older is great. The recovery time required for these viral infections, having that go longer and only being awake 4 hours a day is delightful. Um, there's been a lot of misinformed rhetoric, I'll say, in regards to the COVID vaccines and the flu vaccines. And I swear to God, the next time somebody says that NCI doesn't recommend COVID vaccines for everybody, I'm going to put my head through a friggin' wall. You had a very impressive. This is where you sort of got famous in Alberta in many ways because you did a press conference with the premier and the minister, then Minister of Health, Adriana LaGrange, and they very much did not want to say you should get a COVID shot, and you said you should get a COVID shot. So, what do people need to know about COVID this year? I mean, we're not dealing with, to the best of my knowledge, the like OG flavor of COVID that was like, I'll kill you in 10 minutes. But it still can be very, very serious. Um, what do you have? What do you want people to know about COVID vaccination for this year?
Yeah, get a COVID shot. But worse is, and vaccines work, but no, sadly our systems, our government broke that as well. Like it's broken. Like there's a couple pieces. Like I would like to take a higher level and say that, like, I find it really baffling that we're in an environment now where Alberta, like, we don't have a chief medical officer of health. We don't have robust functioning public health anymore. I mean, we have some amazing public health physicians still trying to do their job that are being muzzled and governed by the government and by the premier's office. And but we don't. Nobody wants that role. There's nobody, expert trained and really well, really know what they're doing, and it wants to come into Alberta and take the chief medical officer of health role. We still can't fill it. And but with that comes that we have this just environment now where uh, there, there's no expert or trusted voice out there trying to give a consensus opinion and try to kind of inform people around what's going on. We just have the premier talking about, what her understanding of what someone might have briefed her for 5, 10 minutes on any of the public health topics. We have an elected official who's talking like an expert on it, and again, this isn't personal to the premier herself. Like, I don't think any premier, unless they were had some expertise in that, should be, basically supplanting and taking over the role of the chief medical officer of health. And sadly, our government has also, really fed into some misinformation and some disinformation around a lot of pieces of this. But again, I'll cycle it back to there's a lot of strong beliefs on this, and it's sad that we've gotten to a position where, there's really good data saying that, people believing in vaccines kind of correlates more now with whether they vote right wing, right or left. Now it's sad that that's a political polarization, but it is there, but I guess what I want to say, bringing it back to a bigger picture, is, and everything I've been talking about the healthcare system and where we're at right now, is that we are as stretched and as bad as you possibly can be going out of this summer. As in the 20 odd years they've been tracking the data, it's never been this bad. Nobody, I kind of dare any of the ministers of health to refute that. Even it is demonstrably as overcrowded and as bad as we've had from any metrics we've ever measured. And we haven't had our seasonal spikes. We haven't seen influenza hit hard. COVID's out there a bit now, and it's going to hit us. RSV is out there. It's going to hit us. It's just starting to come, but we haven't had any of this. But we know, anybody that looks at any graphs for the last 25 years, 50 years, however long we look at, you get big spikes coming in the fall and winter of volumes and complexity, and we're not prepared. Like, we are, so our population is under vaccinated. And then our government created this, again, it's almost this, it's a repeat of decapitate the program we had and have a whole bunch of, new heads and new pieces and roadblocks and steps you got to go through. And one thing we know in public health, everybody knows this. It's not like it's just a fact that anything publicly health related, if you add obstacles or if you make it more difficult, it undermines the policy and the process and the benefits, because you kind of have to, in a way, public health works when you don't get sick, that it's working. And so you kind of have to make it easy for people to stay not getting sick. And so they've really undermined the whole process. They've really made it very, very difficult. And regardless of what your beliefs are about COVID just specifically, and how bad the pandemic was and all these things, it sucked. We all hated the pandemic, but we're all going to pay for it in really significant ways in this fall because of the decisions government's made around our public health and our vaccinations, because it's going to impact every aspect of healthcare as we come into the fall. It's going to impact ambulances, emerge overcrowding, surgical care, cancer care, any type of care you can think of that you're going to have to access in our acute care system is going to be impacted by the volumes and the difficulties we're going to have, because we're woefully underprepared, and we don't have a functional and operating public health and vaccination program in Alberta.
Am I reading? I'm going to put myself on the spot here. Am I reading the NACI recommendations wrong? Because every time I go to them, it says, here's the people who really, really, really should get a COVID shot. And also everybody else should get a COVID shot too. Like, am I getting that wrong?
No, I mean, and part of it is just around the semantics of like who is recommended for and who's suggested for, and that's a little bit of a level of evidence kind of thing, and a little. But I'll just say, government didn't follow even just the high recommendations. As an example, healthcare workers. I mean, they did backtrack after some significant pressure to include healthcare, which is like, again. it's not just healthcare workers though. It's like, our food workers and our people working in grocery stores and essential services, our teachers are they're starting to backtrack and add it into some of the contracts in some of these big groups. But anybody that has to be is essential and may be in crowded spaces and may be more exposed to COVID should have it. That's very clear. But yeah, they just let me just say that the nuances is a little bit around essentially they didn't break it down into like must do and may do, but in a sense that's how the reading is that definitely recommended and suggested, and the suggestion was yes, and for everybody else as well, that there's still good evidence for it. Yes.
Okay. My last topic, and I'm going to preface this a little bit, because I think you were just talking about nuance, and I think that there is a failure to have a nuanced conversation around this piece. There is this, it seems like there is a perception that when we're talking about gender affirming care, um, anybody who enters that pathway is absolutely going to end up in the surgical space. That's the perception. It's certainly the messaging that we've seen from the provincial government. Um, and I think that there are very real conversations to be had about improving the supports that are available to people who are navigating gender dysphoria. I think that it is an incredibly complex conversation. I mean, the whole intersex piece, I haven't seen anybody address that yet, and the genetics don't lie. So what do you want to do? But the it seems like the conversation has now become disingenuous in that the argument that people are making is if somebody starts receiving gender affirming care under medical supervision, they're going to end up getting the surgeries, and that's what's going to happen to every single one of them. And therefore, if somebody even enters the continuum, they will end up, to quote the premier, sterilized. And that is to me a profoundly, again, disingenuous approach. And I don't think that it's fair to say that, um, and this is where I'm going to ask for your expertise. I don't think it's fair to say that simply entering into continuum of care is going to determine outcome. And for that reason, when she does her little pretzel logic and she says puberty blockers cause sterilization, um, that's like saying getting into a car causes car crashes. Yes, there's an absolute correlation with being in a vehicle and getting into a car crash because you have to do the first thing first, but that doesn't mean that there's a causative effect. And given the preponderance of evidence that exists saying that supportive care has tremendous impacts on positive outcomes for people who are dealing with the gender dysphoria piece. Um, do puberty blockers cause sterilization?
No. So I mean, again, like this is sad. This disheartens me, and it's sad that our premier is leading, a discussion around a topic that it seems that she's intentionally conflating things and intentionally using specific words to try to, confuse and or lead to assumptions that aren't true. And so and I'll just say, like I'm a scientist, so let's see the evidence. If the premier is, thinks that that by getting any type of transgender care, you're going to automatically have surgery, like let's see the evidence, let's see the numbers. But again, I can tell you for a fact, like it's not an issue. So in Alberta, as an example, it's like we can demonstrably prove that children under 16 didn't get sterilization surgeries that led to sterilization, as an example. But I'll come back to puberty blockers. But they never got that, and it was never an issue, and it was never something that happened. Although when this discussion comes up at all levels, including to the level of premier, there's this implication or this idea that this was something that was happening a lot and needed the government to intervene to stop it from happening because of course we shouldn't be doing these permanent surgeries on children under 16 when we weren't. So like that's just if you're going to say those kind of things or that let's just show the evidence, let's see what the stats are and let's have a real discussion about it. That's the start. But then the second is like words like sterilization. Like sterilization has a very specific meaning, and sadly, our history with sterilization in the medical community and history and politically, like politicians deciding who should be sterilized. People with mental illness, people with mental delays and or retardation and all these old histories, developmental delays and politicians deciding they should be sterilized and the whole history. That word has a very specific meaning, and it means permanent, and it means that you never could have kids and it's permanent. And to hear our premier conflate that with puberty blockers, it seems intentional to misinform and just and even disinform the public and make it seem like people who go on puberty blockers are going to become sterilized when in fact they don't. Like we use puberty blockers a lot, and we use them for lots of different reasons. And there's medical experts. I'm an emergency physician. I know about this topic. I interact with patients that have this, but there are many, many experts who deal with this day in and day out, who read the literature and understand, and they know the physiology. They studied the physiology. They studied the drugs. They know what they are. Those are who we should be, leading this conversation around what's best. And then ultimately, though, then it comes down to who should decide in society. Is should it be the patients and their parents if they're kids? And the physicians, or should it be politicians that are in the way and doing this? And we're not having that discussion because the premier wants to just confuse us with using specific words that I know for a fact she has seen reports from different groups. I won't name them because I don't want to get them in trouble that have explained, that we weren't doing surgeries under 16 or on under children under 16. We weren't puberty blockers do not sterilize. Like I know that, but sadly, she chooses those words for very specific reasons that that just lead us into not being able to have a discussion or reasoned discussion about an issue that really it's a small proportion of our population, but it has massive impacts on their lives. And you don't hear the premier talking at all about the suicide rates in these patient populations or the children that end their lives and are permanently sterilized because of dying. I mean, you don't. She doesn't talk about those things, so it disheartens me that we're in a situation where our premier is talking like an expert on these topics, and sometimes it seems like she's intentionally. This is my personal opinion. You should have her on here and ask her and get
Oh,
her to explain.
she's been
Yeah.
invited. She won't come.
But my personal opinion is she uses some of these words intentionally just to, conflate and confuse. And sadly, this has huge ramifications on real humans and real Albertans. And you know what? And it's weird. I'll just say it right now. Like it's so weird that we've entered into this environment now. Like I even put out some information around around this topic, and hundreds of people are calling me a pedophile and telling me I'm an idiot and don't have a clue what I'm like. It's such a weird environment to be like, and it seems like our government's encouraging that and throwing intentionally kind of throwing fire and enabling that kind of culture that is just it just doesn't help anything at all. So it's a difficult time, and I really feel for those patient populations. And in the end, I will just say that, I truly believe if Albertans thought about this and the premier thinks she's a libertarian, like I think if the Albertans really thought about who would be best to decide about very complicated medical issues, is it the patients and their parents and the physician? And through a long process and a discussion guided by the evidence, or is it an elected politician that didn't even run on the topic?
And I would just addendum, and I'll take full responsibility for this addendum. An elected politician who may or may not have lost her radio show because she said ivermectin was the cure-all for everything, or hydroxychloroquine, one of the two, and who has encouraged the idea of providing tainted meat to homeless people, and said smoking's good. I mean, it's not even that it's a question of should she be speaking on these things. It's she's demonstrated she's not in any way qualified to deal with these sorts of issues with the sort of weight and consideration that they're due. Um, I want to ask one last. I always do that. I always do that. One last thing. Um, and I want to be clear. I want to reframe the conversation because there is a lot of doom and gloom in here. Things are bad, and I think that there is a responsibility for if somebody knows that things are bad. I think that there's a responsibility to some degree to go, oh, we got a problem here. Like to people who are saying there's a lot of complaining going on about the healthcare system right now. It's good when the canary's making noise. When the canary gets really, really quiet, then you've got a bigger problem. So and I also want to put the appropriate context, particularly for you, as you've said, we are in a political climate right now where trying to raise the alarm about things or speak truth to power can be met with pretty severe consequence. We've seen lots of people fired. We've seen some people allegedly try to have been fired. Um, and so there is I do want to acknowledge and thank you for the courage for it's wild that I have to say that this is the climate that we're in, but I have to thank you for the courage for coming on the show and having these conversations. But I feel like I do. So thank you. My last question. Um, Tell me a feel good story from the last few weeks about something that was awesome that happened in the emergency room. Because as much as there are terrible things that are happening in the emergency room, I can tell you from what I do, there are bad days where you're like, I didn't want to have to do that. But then there's also days where you're like, that was amazing. And that recharged my battery a little bit. So I want to end this on a positive note. Share for our audience, if you would be so kind, a battery recharging experience from the last couple of weeks in the Medicine Hat emergency realm.
Yeah, I mean, so again, like I'll say, it is amazing the stuff we can do, and a lot of us that are staying in this. And so I actually want to preface. I want to tell you too that there's a bit of a revisionist history, a little bit I'm running into now, which is a little frustrating. Of that, if you keep in mind, like my previous head, I was the AMA president, and I actually came in a bit early in my term, and as Minister Lagrange came in, and I spent out of the 16 odd months there's this idea that Parks has just been negative and kind of, crapping on the government and totally just negative against them. And it's like out of the first 16 months, like I spent 13 or 14 months at least in direct meetings and begging them to work together and giving them concrete ideas and not my own. Some are my own, of course, but the teams and from professionals and trying to connect and trying to work really hard and give solutions. And so I find it like a little tiny bit frustrating to be in a position now where I actually feel that if we don't get Albertans to be aware of what the state of our system is right now and don't start talking about this in a really kind of blunt and direct way about, rural Albertans are going to have no hospitals left. Once their hospitals close, they're never going to get them back, or it's going to be really difficult to get anybody in there. Ambulances aren't available for like wide swaths of areas. It has massive impacts on so many Albertans that I really want to advocate to fix the system. And so I get it. Some people are going to just dismiss me of just like pretending that I just hate this specific government or this specific premier. It's not that. It's that I'm saddened and disheartened that it's becoming harder and harder and harder to do our jobs every day, myself and my colleagues and everybody on allied healthcare, any front you name it. And so I think we have to have a really, really reasoned, and we just have to, all Albertans have to start thinking about this, because it's like you don't know what you got until it's gone, and a lot of people are now starting to show up and emerge, or going to get cancer care and seeing it's not there for them or their loved ones. And so, but to tell you why that I still keep going on and still beacon and still yelling is that it is amazing how we can touch people's lives when we can do our job. And so within anonymizing, I had a patient that was under 35 that had a cardiac arrest at home, and that doesn't happen a lot for young people. And and came in by ambulance responded in a really quick time. The paramedic crews, we weren't on red alert, and they did their job really quick, and were able to get some the pulse back and get the patient to us. And then after a prolonged resuscitation of like a couple hours and multiple times of losing pulses, and the patient, in simple terms, dying, and us bringing them back. And after our crew, like our team, working like, like the well-oiled machine that we are, getting them stabilized enough with some of the amazing modern medicine and things we're doing, and then getting a fixed wing transport to Calgary, and then getting that patient into Calgary and seeing the heart specialist, and then finding it was a very kind of rare and atypical type of um, in simple terms, how their internal pacemaker worked. And so in the end, though, to get feedback and hear, and then to be able to meet that patient, after a couple months have passed, to have them come back and say thank you to the team, and to realize that we can make that kind of impact on people's lives. That's why we're talking about this. That's why I'm talking about this, because on another day where there was no EMS and we were red alerts, and our emerge department was so overcrowded, and or maybe there's no fixed wing and no spaces in Calgary, maybe that person wouldn't have been around to come back in a couple of months and say thanks to the team, and still living and totally healthy and fine. So, the system's amazing when we can work, and that's why we're here advocating and discussing and trying to say, this isn't about politics and a partisan one, what government, this is about, let's make our system work.
Perfect. That was an excellent story. Thank you. I wanted to leave it on a positive note, and you accomplished exactly that. Dr. Paul Parks, thank you so much for taking the time to chat. And I look forward to the next time that we get to have you on the show as well. Because I think last time we did a happy story at the end too, and I just like the happy stories. They're nice.
It's good. There is some positive in there.
100%. Thank you so much, sir.
Thanks.
And that's it for another episode of The Breakdown. As always, if you appreciate the kind of content that we're trying to produce here, we would love nothing more than if you thought about signing up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab, where for just the price of a fancy cup of coffee a month, you can help us continue to produce this kind of content. Whether you're listening to the audio version of the podcast, in which case, maybe leave a review and a rating, or whether you're watching it on one of our streaming platforms, we want to say a big thank you to everybody who is part of the Breakdowns audience. And as always, take care of each other and keep the conversation going.